Good afternoon. So first let me apologize once more for the little glitch we had with the program, as one of our speakers could not make it. It gives me great pleasure to introduce to you Dr. Nisreen Rizq. Dr. Rizq graduated from AUB in 2001, and she spent a fellowship at Case Western in Ohio in ID and in HIV. She moved back to Lebanon after a career in New Haven, and she is going to talk to us about pulmonary infection, HIV, and AIDS. Dr. Nisreen.
Thank you. Thank you. And, thank you for coming back today. And thank you to the organizers for inviting me to speak to you today about pulmonary infections in HIV and AIDS. Can we dim the lights, please, بس شوي أكتر? Because the background is... Okay, thank you. So ever since the onset of the infection in the early 80s, HIV infection has spread rapidly between people and throughout the world, and has caused so far around 25 million deaths. In a recent estimate in 2008, the UN AIDS estimates the number of people living today with HIV and AIDS in the world to be around 34 million people. The majority of those individuals live in resource-poor nations. And historically also, pulmonary diseases have accounted for a large percentage of both infectious and non-infectious complications of HIV. And with the introduction of antiretroviral therapy, the epidemiology of those AIDS or HIV-associated lung diseases has changed dramatically, and especially in those countries with rapid or where treatment is available and readily accessible to most patients. There has been a shift in the epidemiology of pulmonary infections between the years, the pre-ART years, and where we would, the most common infections or the most common presentations of HIV and AIDS would be Pneumocystis Pneumonia, Tuberculosis, and Bacterial Pneumonias, versus nowadays and today, and again, looking at resource-rich countries or developed countries, where the infectious diseases are becoming less common in HIV and AIDS, although still present and prevalent, but diseases like emphysema, COPD, pulmonary arterial hypertension, and lung cancers appear to be increasing, and where we're also witnessing a new category of syndromes that are associated with ART use and side effects. So the understanding of the pulmonary immune response in HIV-infected people has really greatly also improved over the past several years. And this graph here will show, this figure here highlights this fact. And looking at clinical manifestations in parallel with systemic effects of the HIV infection and lung alterations in parallel again, and following that over time, and with the natural or the progression of the HIV infection, comparing early stages and early manifestations of bacterial pneumonia, tuberculosis, and oral thrush, which coincide, as you all know, with a relatively higher level of CD4 count, both in the systemically and in the BAL. And following this over time, when the disease is progressing, HIV disease is progressing, causing a drop in the CD4 count, both systemically and in the BAL, with an increase of the CD8 positive cells, more pronounced in the BAL than systemically, and that coincides with the onset of the classic or the traditional opportunistic infections or lung infections, Pneumocystis pneumonia, disseminated TB, atypical Mycobacteria, and others. And when a person starts ART, and you see that on the here, with the initiation of heart, there is an increase back of the CD4 cell count, and an expansion of the naive cells and out of the memory cells, and that is going to coincide with initially a period of where there is a risk of developing iris, and we'll talk about this later, and followed by a sustained increase of the CD4 count above 200, and which again will mean that immune restoration has happened, and those infections will be unlikely to occur. Now, evaluating a patient presenting with pulmonary complaints is actually can be challenging, especially if that person is infected with HIV. Respiratory symptoms are frequent complaint among HIV-infected individuals, and the spectrum of those illnesses can be HIV and non-HIV related. And looking at the HIV-associated pulmonary conditions, those include opportunistic and neoplastic diseases as well. And when we look at the opportunistic infections related to HIV and AIDS, we're talking about bacterial, mycobacterial, fungal, parasitic, and viral pathogens, and I'll try to give you a quick overview during today at this talk. The frequency of respiratory symptoms in HIV has been studied. I was expecting to see way more studies, but unfortunately not that many. The first study, the Pulmonary Complications of HIV Infection study, started recruiting in 1993, and in the U.S. followed patients, a large number of patients for several years, and those people were all obviously HIV infected with HIV, had different races, ethnicities, and came in with different HIV transmission categories, and came in also with a wide range of CD4 cell count. And following, so the focus obviously was pulmonary disease and trying to stratify and look at the epidemiology and following people prospectively. Gathering clinical and radiographic data, and whenever possible also trying to get a definite microbiologic and a pathologic diagnosis of an infection. And one observation was that respiratory symptoms are common among HIV-infected individuals, and they increased frequency with a drop in the CD4 count below 200. And this slide, or this table here, represents that, where you see a comparison between the frequency of symptoms in people who are HIV infected with any cell count, any CD4 count, versus people whose CD4 count is below 200. And for example, cough is a pretty common finding. 27% of people followed in the study had that as a symptom, and you see that this increases to 34% when the CD4 count drops to below 200. Another study tried to replicate those findings, but it was a smaller scale study. The respiratory symptoms among HIV seropositive individuals study. The results were published or some of the results published in 2003. Also tried to look at different symptoms and different pulmonary presentations in HIV-infected people, and comparing them, though, to HIV-uninfected individuals. And you see a drastic, really dramatic differences in whether it's dyspnea, cough, or phlegm production. The difference is extremely, is huge. And one conclusion from that study was that current or past cigarette smoking is the most important predictor of respiratory symptoms among HIV-infected individuals. So, in going back to the first pulmonary complications and HIV infection study, another observation was that the introduction of ART or and HART, which is the highly active antiretroviral therapy, coincided with a drop in the frequency of HIV-associated opportunistic infections and neoplasms. And in contrast, as you would expect, non-infectious complications like COPD and PAH, lung cancer may be increasing. HIV infection alone appeared to be a risk factor for the development of COPD and pulmonary arterial hypertension. Again, in keeping with this, the rest of the other complications. Upper respiratory tract infections are more common in HIV-infected individuals, obviously irrespective of the CD4 count, than invasive bacterial or non-bacterial diseases. And here we're looking at the incidence of these conditions that cause respiratory symptoms in HIV-infected patients from following people over time and following individuals over 5 years, irrespective of the CD4 cell count, looking at the frequency of upper respiratory infections and bronchitis, they account together to more than, and even following people over years, they account to more than the incidence of PCP, bacterial pneumonia, and tuberculosis combined together. So pretty much HIV-infected individuals, basically when they present with a respiratory symptom, usually the etiology can be the same as an HIV-uninfected individual. The spectrum of pulmonary infections varies also widely. Whether based on this setting, the clinical setting we're looking at. In outpatient clinical settings, the spectrum of those diseases is basically more dominated by upper respiratory illnesses and bronchitis versus an inpatient or hospital setting where you see more opportunistic infections, and compared to an ICU setting where the shift is still nowadays more towards PC pneumonia. There is an increase in pulmonary diseases in the current HIV era. And I wanted to talk to you briefly about IRIS, which is the immune reconstitution syndrome, that basically presents most of the time with a presentation directly against the pulmonary pathogens in different forms, like presents as a reactivation, as TB, or can mirror PCP or MAC. And IRIS is we refer to IRIS, the immune reconstitution syndrome in HIV, refers to the constellation of syndromes that can occur after starting antiretroviral therapy on an individual whose CD4 count was below 200 or even sometimes even lower. So, and the premise is that the person's immune system is heavily suppressed, the CD4 count is very low, and you're introducing drugs that are going to create or cause an elevation in those and the CD4 cells and in immunity in general. And so the experience, the clinical experience, shows that during this period of time, right after introducing or starting antiretroviral therapy, a lot of people come in with symptoms and presentation that mirror or that look like opportunistic infections. And basically what is happening is that because of this immune reactivation following starting ART, all of those pathogens or those opportunistic infections were laying there, the person could not fight them, and now that the CD4 count is back up and the immune system is back in working, this is going to translate in symptoms and syndromes that we call IRIS. And again, pulmonary presentations in IRIS are very frequent. So this is something to keep in mind when evaluating someone, especially if they had AIDS and recently restarted on ART, presenting with respiratory symptoms. I'm going back, sorry. Okay. The epidemiology of HIV-associated lung diseases can differ between the setting, obviously, also in rich and poor countries. When we look at the US and Europe, the experience is, as we've mentioned and as we've just said, PCP and TB decreasing in frequency. Even pneumococcal disease has decreased in frequency due to the introduction and the intensification of the vaccine use, the pneumococcal vaccine use. However, community-acquired MRSA is one disease that is on the or that rose, not dramatically, but has been described more commonly. And there's an association between community-acquired MRSA carriage and the HIV status of a person, and this carriage is more frequent the lower, or this nasal carriage of MRSA is more probable, is more common in people who are infected with HIV and with a lower CD4 count. Now, looking at low-income and middle-income countries, I have been back for a few months, but I can start to see the differences between, in terms of access to medications and clinically. What we see here, or in our countries, is way more HIV-associated pneumonias, typically TB, and obviously a lot more AIDS than I was seeing in the US for so many years. TB is a problem in developing countries. It was a problem before HIV. It became more so a problem after HIV, with an increased incidence of 20-fold because of HIV alone. And that you can imagine, that can cause a problem, so many problems for HIV-infected and uninfected individuals in any community. The diagnostic approach of respiratory symptoms in an HIV-infected individual starts obviously with a history and physical examination, and knowing the CD4 count can help a lot, because it's going to basically be your most important predictor of, or an excellent indicator of the possible infection, if it is an infection we're dealing with, because the CD4 count reflects the degree of immune compromise, and it's going to give you an idea about the possible diagnoses and guide you towards developing a diagnostic and a therapeutic plan of action. So here we're looking at a slide that is showing the association between pulmonary infections with different CD4 strata, a lot of tables and a lot of data on this. If a CD4 cell count is greater than 500, the pulmonary infections that can be mostly seen are pulmonary TB, pneumonia, and sinusitis, bronchitis, acute pharyngitis, versus a CD4 count of less than 500, more than 200, recurrent bacterial pneumonias. When you hit the 200 mark and the AIDS mark, and that's the significant immune dysfunction, that is translated clinically in the appearance of more PCP and disseminated tuberculosis. When when the CD4 count hits 100, that's when we start seeing disseminated MAC, invasive fungal diseases, and even CMV pneumonitis. Though the CDC looked at also most of the data we have basically come from this study, the Adult and Adolescent Spectrum of HIV Disease Project, conducted by the CDC, that provided information on thousands of people. They followed basically 22,000 HIV-infected individuals over time, and not only for pulmonary disease, but they were looking at everything. And specifically looking at the lungs, one conclusion was that the vast majority of bacterial pneumonias and pulmonary tuberculosis occurred in subjects whose CD4 count was less than 400. Whereas bacterial pneumonias were more common, or a more common presentation than pulmonary TB in that group of people. And that famous, what we know, that the majority of PCP episodes occur in subjects with a CD4 count of less than 200, basically was established. That was a clinical observation established by the results of this study. So now, looking at pulmonary symptoms that a person is presenting with, the most likely HIV-related infections would be that present with significant respiratory symptoms and are PCP and pneumonia caused by bacterial pathogens. There is a difference between the presentation of PC pneumonia and bacterial pneumonia. I'm not going to spend a lot of time discussing this because we'll go back to it in a little bit. Now, looking at also diagnostically, when evaluating a patient, it helps to know the HIV transmission category or mode and the person's habits, obviously, because they will most likely influence and affect the illnesses that person can have. For example, looking at HIV-infected people with IV drug use, you may consider, if they're presenting with a picture of bacterial pneumonia, you may want to consider Pseudomonas or Staph aureus as a cause of the bacterial pneumonia because of their IV drug use. Smokers in HIV patients smoke more than the rest of the population, by the way. So that's very important. And as pulmonologists, I think you see this a lot. And that translates to more bacterial bronchitis and bronchopneumonia in HIV-infected individuals who smoke compared to those who don't smoke. And smoking, as we said before, is a leading cause of death in HIV-infected individuals today and a leading cause of lung cancer. And also a leading cause of pulmonary infections. Travel and residence, where the person lives, what they do, where they've traveled, where they've been, is very important, especially in our looking in our country, in this country, and the neighboring countries. We live in a place with high prevalence of tuberculosis. So tuberculosis is obviously a major concern. If your patient has traveled to China, for example, or has been in the US or a different location, that can also influence the kind of disease that they present with. Previous lung conditions and prophylaxis use is important if the patient is compliant with prophylaxis use, let's say Bactrim. It is unlikely, even if they're presenting with a pneumonia, it is unlikely to be PCP versus someone who's not compliant and not taking their medications and not following the recommendations. Now the signs can be, there's a huge overlap obviously between the signs on physical examination, especially in lung disease, but there are certain typical things that can raise your suspicion. For example, PC pneumonia presents with desaturation, hypoxia, and an increase in the AA gradient. Bacterial pneumonias present more with focal lung exam abnormalities. If a person has asthma and they have HIV, obviously if they're wheezing, that's an asthma exacerbation, and so on. Also I think we see a lot of individuals who present to our healthcare with advanced HIV or in AIDS. I think it's important to keep in mind, the rest of the physical examination, like the skin. I don't think we see a lot of disseminated fungal or invasive fungal diseases here, like histoplasmosis. I don't know what your experience is, but for example, on the abdominal exam, for example, hepatosplenomegaly can tilt you to consider something like disseminated MAC or non-Hodgkin's lymphoma when evaluating someone with HIV. Laboratory test, the CBC, the total white count is obviously very important. The LDH level, we'll talk about that because it's been very linked to PCP. And though an elevated serum LDH suggests PCP, it doesn't always have to be elevated in PCP. So it helps you when it's high, but it doesn't rule it out if it's low, especially in people coming and if you're seeing someone in an outpatient clinic where the PC disease is mild, versus hospitalized patients or patients in an ICU with PCP, the LDH level typically is way higher and can confirm your diagnosis. Okay, so now going to the chest X-ray, it is your friend, it is what you use, and you're experts in this way more than I am, but it is a very important diagnostic tool, especially again to differentiate between if you're suspecting PC pneumonia versus bacterial pneumonia, or looking at considering TB in someone who's coming in with hemoptysis, and so on. Now, a few slides here and I don't think we'll have time to go through this in detail, but different characteristics or chest X-ray characteristics can mean or would suggest specific HIV-related opportunistic infections and neoplasms, diffuse or multifocal infiltrate goes more for PCP versus a focal infiltrate that can be seen with bacterial pneumonias. Reticular or granular pattern of infiltrate classically means PCP until proven, I think, otherwise. Nodular pattern or nodules, more suggestive of tuberculosis. Miliary pattern, also more suggestive of tuberculosis, irrespective of the CD4 count. Cysts are seen with Pneumocystis pneumonia. Pneumothorax can be a presentation of Pneumocystis pneumonia, and so on. The chest, the CT chest or a chest CT, in most cases it's not necessary because you can get your diagnosis talking, examining, and looking at a chest X-ray of your patient and trying to get either a sputum culture or even if you decide to go ahead and get a bronchoscopy. But high-resolution CT scan can be helpful in when you clinically suspect PCP and your chest X-ray is negative. So the appearance of ground glass infiltrate on the high-resolution CT will confirm your diagnosis of PCP, and if it's absent, then you can almost rule it out. Looking at nodules, again, the size and the distribution of the lung nodules, the CT chest can be very helpful in looking at that and revealing or giving you your differential diagnosis. Here is a table that goes over the diagnostic approach to pulmonary disease in HIV and HIV patient, and again, looking at HIV, and then whether they are on prophylaxis or not, compliance or not, and then the second level would be focusing on the CD4 count if it's above or below 200, with different, changing the likelihood of given infections as you go. Pneumocystis pneumonia, I don't think we have time to go through the different kinds of, or the differences between pneumocystis pneumonia, bacterial pneumonia, and HIV. I wanted to talk also a little bit about tuberculosis, but I think we've mentioned that. Nontuberculous mycobacterial disease, we didn't discuss it very briefly, but MAC in HIV happens when the CD4 count is really below 50. So, and usually the presentation is that of fever, night sweats, weight loss, fatigue, not really pulmonary complaints, and the diagnosis is usually done through a blood culture, positive for MAC. Fungal pneumonias, again, I don't know about the Lebanese experience with histoplasmosis, if it's an endemic disease here or not, but in the US, it's pretty prevalent and causes significant disease and a lot of mortality, especially when the CD4 count is less than 50. CMV pneumonitis rarely causes disease, I think, rarely causes lung infection in HIV, and its presence in the BAL or in the lungs of someone doesn't always signify disease. As you know, is it the reactivation because of the immune dysfunction, or is it causing the disease in itself? Is still not very clear for non-HIV infected patients and HIV infected individuals as well. I think I will stop here, and thank you for coming.
Thank you, Dr. Nassim, for an excellent overview. The floor is open for discussion, and I wanted to start with one. Clearly, you've mentioned that pulmonary hypertension in HIV disease is much more prevalent. So in your practice, how do you screen for patients with arterial hypertension? Do you have a certain protocol where you wait for symptoms? Do you do it earlier? How do you do that?
I think we usually wait. We usually wait for symptoms to develop. Obviously, there are, and keeping that in mind, I don't have a protocol I don't have any, a lot of, I didn't look at the most recent evidence for this, preparing for this talk today at pulmonary arterial hypertension specifically, because Dr. Mukhbat was going to talk about this. But I'm not aware of a specific protocol screening for that on everyone who has an HIV infection on the get-go. We could, for example, versus other types of screening in HIV-infected individuals, like cardiovascular mortality is twice as high as in people who are not infected with HIV. And even though we know this, there are no guidelines that would that guide us and say, you have to get a stress test on any male who's 50 who has HIV if they're presenting without symptoms. So I doubt there is anything like that in the guidelines for specifically pulmonary artery hypertension, but again, I may be wrong.
Any other questions from the floor?
All right. Thank you.
Well, thank you so much.
Thank you.